management of pain, and you have also dealt with step 1 of pain management. So today we'll be discussing in detail about the opioids. Next slide, please. So what all will be discussed today? That includes the commonly used opioids, the mechanism of action of opioids, the practical aspects of opioid use, adverse effects of opioids, and the price of different opioids. And just to remind you, the WHO analgesic ladder for cancer pain management. As you might be remembering, I hope you all have already gone through this analgesic ladder and you might be remembering this. So the step 1 of the WHO analgesic ladder, that is for mild pain, includes non-opioids plus or minus adjuvants. And if the pain is increasing, we go to step 2 of the analgesic ladder, which includes opioids for mild to moderate pain, plus or minus non-opioids, plus or minus adjuvants. And if the pain is more severe, then we move on to step 3 analgesics, which include opioids for moderate to severe pain, plus or minus non-opioids, plus or minus adjuvants. I hope you all are clear with this WHO analgesic ladder. So today, as I already mentioned, you have already done non-opioids. So today we will be handling with the opioids. So we'll start with the patient scenario. So 56-year-old man with diagnosed with carcinoma of larynx had a severe pain, 10 on 10 intensity around the neck, which was sharp with no radiation since last 2 weeks. And because of the pain, he was unable to sleep. How will you manage? I would like this session to be an interactive so that it helps in learning better. So suppose a patient, a 56-year-old patient with severe pain, 10 on 10 pain, comes to your OPD and the pain presentation is a sharp, not radiating pain affecting his sleep. How will you manage? Any suggestions? You can unmute and talk, or you can type in your chat box, please. Yes? So, Ashwati, right?
Yes, Ashwati.
Yeah, so Ashwati says that if it's severe pain, we might need opioids, okay? Give painkillers, strong opioid. So, okay, so which are the strong opioids? Morphine, okay? Okay. Fentanyl. Okay, thank you. Thank you for the responses. So, yeah, so we understand that this pain is severe pain, which is, so which is severe in intensity, 10 on 10, the score is 10 on 10. So that means that the patient needs medications of step 3 of the analgesic ladder. One step back. So we have gone through the analgesic ladder, and you know already that this opioid for moderate to severe pain, the patient is on severe pain, so preferably opioids for moderate to severe pain, which includes morphine, fentanyl, methadone, etc. So yes, you're right. So since the pain is 10 on 10, we need an immediate relief. So how do we go about that? So the next step would be intravenous morphine titration. Anybody has any idea what is intravenous morphine titration? Anyone want to comment on that? Okay. So intravenous morphine, yeah. Thank you. Thank you for the responses. So intravenous morphine titration is done for patients with severe pain. If you have the injection morphine available with you, you can do this titration process. So the titration process includes, so 1 ampule of morphine contains 15 milligram of morphine. So that is 1 ml of ampule is 1 ml. 1 ampule of morphine contains 1 ml. So that 1 ml of morphine contains 15 milligram of morphine sulfate. So this 1 ml is titrated with 9 ml of the diluent, normal saline, and make it 10 ml. So that is 1 ml contains 1.5 milligram of morphine. Is it clear? So 1 ampule of morphine is 15 milligram of morphine. And this 1 ampule is diluted with 9 ml of normal saline, and this is made to 10 ml. So 10 ml of the diluent contains 15 milligram of morphine. That means 1 ml contains 1.5 milligram of morphine. So this 1 ml of morphine is given to the patient in every 10 minutes interval. So that is how morphine titration is performed. So before we start with the morphine titration, we need to check the vitals of the patient, the respiratory rate, and we need to assess the pain score of the patient. And before starting with the titration process, we need to give the patient injection metoclopramide. Morphine can produce emesis. So an antiemetic needs to be given before starting with the morphine titration. So injection metoclopramide 10 milligram is given before the titration, starting of the titration process. And we need to record the vitals of the patient along with vitals, which includes the respiratory rate as well as the pain score of the patient needs to be recorded. And this 1.5 milligram or 1 ml of morphine is repeated in every 10 minutes until the patient has satisfactory pain relief or the patient becomes drowsy, whichever occurs earlier, would be the end of the titration. So Neelam has asked what will be the maximum dose for morphine titration. So the end of titration, dose titration would be depending upon the reduction in the pain score or once the patient becomes drowsy, whichever happens first would be the end of the dose titration. So the end point of titration is either satisfactory pain relief or sleepiness. So to give you a better, whichever happens first, to give you a better idea of the titration process. Next slide, please. So suppose the patient has started on morphine titration at 10 o'clock, record the vitals and record the pain score of the patient. So our patient has 10 on 10 pain. We have recorded the pain score and drowsiness is also noted. The patient is not drowsy now. We gave the patient 1.5 milligram of morphine. That is 1 ml of morphine. After 10 minutes, check the pain score again, check the vitals and the pain score. So the pain score has come down to 7. The patient is still not drowsy. We give another dose of morphine. That is another 1.5 ml of morphine is given. Sorry, 1.5 milligram of morphine is given. Now, after 10 minutes, again check for the pain score. And it has become 4. But patient is still not drowsy. So another dose of morphine, 1.5 milligram is given. And after 10 minutes, the patient is again checked. And the pain score has come down to 1. And there we stop the titration. So in this patient, this is an example or a patient scenario where we have given 3 doses of injection morphine. And the pain score has come from 10 to 1 by 10. In 10 minutes interval, we have given this. And a total of 4.5 milligram of IV morphine was given to this patient. And the patient had satisfactory pain relief. Is it clear? The morphine titration? Are you all with me? This is very important to understand the morphine titration. Okay, thank you. Thank you for the responses. So now this patient is on. So we know that we have done the morphine titration and our patient who was on 10 on 10 pain, the pain score has come down to 1 by 10. But now we want to send this patient home. What do we do? We cannot send the patient on IV morphine home. So what else can we do? Any idea? Anybody wants to respond? Yes, yes, Kumari. It is. We'll convert to oral morphine. Very good. So how do we send the patient home? So the patient, the IV morphine is being converted to oral morphine. So how do we do that? So after the morphine titration, it is 1:1 conversion rate. So for the patient has been given 4.5 milligram of IV morphine and had adequate pain relief or satisfactory pain relief. So this patient, the IV morphine can be converted to 4.5 milligram of oral morphine. So that is 5 milligram of oral morphine. The patient can be sent home on 5 milligram of oral morphine. So it is 1:1 conversion for morphine titration, IV morphine titration. After the titration, when we have the state pain relief, adequate pain relief, then we do 1:1 conversion to oral dose. So 4.5 milligram of IV morphine is being converted to 5 milligram. That is the next available dose. Morphine available dose is 10 milligram. So we can take half the dose. So 5 milligram of oral morphine, the patient is sent home. Next slide, please. So do you remember the principles of analgesic use? Anybody remembers the principles of analgesic use? So it is always safe to use the analgesic by the clock, by the mouth, by the ladder, and individualized treatment. What does that mean? Always, if it is possible, give the patient or medications orally. And what does by the clock means? At the correct frequency. So morphine is a drug that has to be given every 4 hourly. So the patient needs to be given the medication every 4 hourly. What does by the ladder means? As per the WHO analgesic ladder. So depending upon the severity of the pain, the patient is given step 1, step 2 or step 3 analgesics based on the severity of the pain. So that is by the ladder. And individualized treatment means it's each patient has to be treated as an individual patient and they had to be provided individual treatment options. So that is the principles of analgesic use. So for oral morphine, so now we have done the IV morphine titration and converted to oral morphine. And now we are sending the patient. So the morphine tablet available is 10 milligram. So the patient has to be given every 4 hourly. So 5 milligram at the time the patient wakes up, then 10 a.m., then 2 p.m., 6 p.m. and at bedtime we give the patient double dose. This is because we don't want to wake the patient at 2 a.m. and give the half the dose again. So we are trying to attain a stable analgesic level in the blood throughout the night with the double dose at the bedtime. So usually at bedtime, we give a double dose. And the patient is given the same dose, 5 milligram as SOS dose. So as rescue dose to be used whenever needed. Next slide, please. So how do we go about the oral? Suppose the patient comes to you and you don't have an IV morphine preparation. You have an oral morphine. What do we do? So in that situation, so we did the pain assessment, we did the overall assessment and understood that the patient was having severe pain and the drug of choice would be the step 3 opioids and we want to start them on oral morphine. So how do we go about that? So suppose the patient, we want to start with oral morphine to a patient who is new to opioids. We start with 5 milligram 4 hourly. So tab morphine 5 milligram Q4H, 10 mg at HS bedtime and 5 milligram SOS. Suppose the patient is already on weak opioids, that is step 2 opioids like tramadol or tapentadol. If the patient is already on, then we can start the patient with either 7.5 or 10 milligram of oral morphine every 4 hourly. So that is oral morphine titration. Next slide, please. So we are moving on with the patient story. So the patient, after undergoing the morphine titration, IV morphine titration, we found that the patient had pain relief with 4.5 milligram of IV morphine. Then we wanted to send the patient home. So we converted the IV morphine to oral morphine. And now the patient is on 5 milligram of Q4H of morphine and 5 milligram SOS dose. So he was relatively pain-free for 2 weeks. And he needed 3 rescue SOS dose of morphine per day for the last 4 days. So since the last 4 days, he was needing around 3 SOS dose of morphine per day. What shall we do now? How frequently would you give SOS dose of oral morphine? Any idea? Any comments? So the patient was having adequate pain relief, but since last 4 days, he's taking around 3 rescue doses per day of morphine. What do we do? What does that indicate? The patient is needing more rescue doses. What does that indicate?
Ma'am, we need to increase the doses.
Yes, Sheetal, thank you for that. We need to increase the dose. It's a clear indication that the pain relief is not satisfactory with the current dose and we need to increase the dose. How do we increase the dose? So, when 2 or more rescue doses are taken per day, we need to increase the dose by 30 to 50% every 24 hours. So that is 30 to 50% increase in the dose is needed when more than 2 rescue doses are being taken in a day. So you can increase the dose. The patient was on 5 milligram of oral morphine 4th hourly. Now you can increase the dose to either 7.5 or 10 milligram 4 hourly. So that is how we increase the morphine dose. So there was another question. How frequently would you give SOS dose of oral morphine and why? Anybody wants to comment on this? Is there anyone who's using morphine in their center?
Yes, ma'am, we are using.
Okay, so Shidal, how frequently would you give SOS dose of oral morphine?
Ma'am, whenever patient feels pain, we give morphine.
Yeah, but yes, whenever the patient has pain, we ask them to take the SOS dose of morphine. But do we set any any gap between the 2 doses?
Yes, ma'am, we need to keep some gap because morphine has some side effects like respiratory depression. So I think we need to assess the patient before giving the stat doses.
Yeah. So what would be the duration between 2 SOS dose?
Ma'am, I'm not sure, maybe at least 2 hours.
Yeah. So thank you, Ashwati, for that. To understand that better, we need to know more about morphine. So we'll be going to that. So morphine is a naturally occurring opioid, and it is extracted from the poppy plant Papaver somniferum. So morphine is legally cultivated in Uttar Pradesh, Rajasthan, and Madhya Pradesh. And moving on to the pharmacokinetics of morphine, we'll be discussing about the absorption. So morphine is a weak base and it is, when taken orally, it is absorbed from the upper part of the small intestine. It is hydrophilic in nature, so its action is slow in onset and has longer duration of action. And when it is given sublingually, the absorption is very low. And research say that buccal and gingival absorption also there is variable results, and it has got a bitter taste. And regarding the metabolism of morphine, so when once morphine is swallowed, it reaches the gastrointestinal tract and it is absorbed into the blood vessels, and it enters the portal vein, and from where it reaches the liver. So morphine is metabolized in the liver and the metabolites are released into the systemic circulation. So as I said, the morphine undergoes metabolism in the liver and it gets metabolized. It forms its metabolites. So majority of metabolism or mainly the metabolism of morphine takes place in the liver. But a minor part of the metabolism takes place in the gastrointestinal tract as well as in the kidney. And the morphine, 90% of the morphine gets converted to its metabolites. And we have mainly two metabolites that is formed after the glucuronidation of morphine, and that is morphine 3-glucuronide and morphine 6-glucuronide. This morphine 6-glucuronide, which is around 5 to 10% of the total morphine, is responsible for the analgesic effect of morphine. So, just to understand, that is, the metabolism of morphine takes place in the liver, and in the liver, morphine gets converted to its active metabolites. So there are two active metabolites of morphine, that is morphine 6-glucuronide and morphine 3-glucuronide. And this morphine 6-glucuronide is responsible for the analgesic effect of morphine. So this metabolism, and to peak its analgesic effect in the blood, it takes around 45 to 60 minutes for the morphine to produce its peak effect in the blood. So once a dose of morphine is taken, we will have to wait for a period of 1 hour. So this is why an SOS dose, there would be a gap of at least 1 hour. So once the morphine is taken, it gets absorbed and then it reaches the liver and it undergoes metabolism and it gets released into the blood. And the metabolites, to peak its analgesic effect, it takes around 45 minutes to 60 minutes, 1 hour. So usually the SOS dose of morphine is given in a gap of 1 hour. So we ask the patient, if you have pain, you take morphine. If you suppose you have taken morphine at 7 a.m., we'll ask them to wait for at least 1 hour till 8 a.m. And if the pain still persists, and if there are no side effects, then you can take another SOS dose. So a minimum of 1 hour gap is advised between two SOS dose of morphine. Moving on to, so the patient whom we have started on morphine. So we have so for the patient is on 10 milligram of morphine 4 hourly, but he finds it difficult to take it every 4 hourly. He says he's willing to take it, but if you give less frequently, what will you do? So the patient is willing to take the medication orally, but he is worried about the frequency. He's not ready to take it every 4 hourly. He's asking whether you can do something to reduce the frequency. What can be done? Any suggestions?
Ma'am, we can convert into sustained release morphine.
Yes, very good. So there comes the sustained release preparations. So the sustained release morphine, the duration of action is around 12 hours. So BD dose can be given. So this patient who was on 10 milligram of oral morphine, 10 milligram 4 hourly. That means 60 milligram in 24 hours. So that patient can be given 30 milligram sustained release BD twice daily. So he doesn't have to take every 4 hourly, it's just a BD dose. So sustained release preparations can be used in such patients. Yes. Thank you, Sheetal, for that. Moving on. This brings us to the importance of different preparations of morphine. So morphine is available as aqueous solutions, tablets. Tablets can be immediate release as well as sustained release. And also we have injectable preparations of morphine. Next. So we have the patient who was on 10 milligram of morphine 4 hourly for the past 6 months. He was on 10 milligram of morphine and he was brought to you with excessive drowsiness. On examination, it was found that he has a serum creatinine of 5 milligram per deciliter. Will you do anything with the morphine dosage? So the patient is on 10 milligram of morphine 4 hourly, but now reported to us with excessive drowsiness. And his serum creatinine was found to be 5 milligram per deciliter. How do we move forward? Any suggestions?
Stop the morphine.
Stop morphine? Yes, Kumari says reduce the dose of morphine. Yes, Pratima. Why? Yes, we can reduce the dose of morphine. Why do we want to reduce the dose of morphine?
Because of drowsiness, ma'am.
What could be the reason for drowsiness?
Serum creatinine low serum creatinine.
Yeah, yes, Sheetal. So that is, yeah, you're right. We need to reduce the dose of.
Patient creatinine level also high, ma'am.
Sorry? Sorry, who was talking? Yes, so you are right. The patient is showing drowsiness. So we need to reduce the dose of morphine. But why this drowsiness? There comes the importance of knowing the excretion. How is morphine excreted from the body? So we said that it is metabolized in the liver and the metabolites are released into the blood. So morphine is excreted mainly by glomerular filtration. So what happens in renal failure is that the active metabolites morphine 6 glucuronide as well as the morphine 3 glucuronide accumulates in the blood and the clearance will be decreased and so its availability in the blood is increased. So what happens is that the analgesic, so morphine 6 glucuronide is responsible for the analgesic effect, as I have already mentioned. So this remains in the blood for longer period of time. And so what we need to do is that either increase the spacing or make the dose thrice daily, reduce the dose, or alternate opioids can be used. So suppose the patient is having a renal failure, there is high chance of this morphine metabolite responsible for the analgesic effect, that is the morphine 6 glucuronide getting accumulated in the blood. So we need only, so this can bring in toxicities. So we need only reduced dose of morphine. So either you can reduce the frequency of the dose or you can reduce the dose itself. So either you can make it, the dose can be reduced or you can increase the spacing between the doses. So what can we do is that, so for this patient, we can send him with 5 milligram 8th hourly. So the patient was on 10 milligram Q4H. Now we have reduced the dose to 5 milligram 8th hourly. So now another patient, hope, am I clear in that?
Yes, ma'am.
Okay, thank you. Thank you for that response. So now this patient is sent home and is now on 5 milligram of oral morphine 8th hourly. But after 2 months, as he is getting terminal, he is unable to swallow anything. What will you do now for the pain relief?
We try for IV injection, ma'am.
So the patient is at
Injection.
home. Patient is at home. The patient wants his end of life to be at home. Do we have any other options?
Fentanyl batch, ma'am.
Yeah, opioid switching is one option. Suppose we don't have a fentanyl with us or it is very expensive.
Ma'am, we can try to put rice tube and then we can give medicines.
So the patient is in his terminal stage and we understand that the patient is in his terminal stage. So would it be wise to advise an NG tube insertion in this state for the patient? Is there any other option?
Ma'am, can we give sublingual?
So we have already seen in the
Correct.
absorption that the sublingual is absorption is very less.
Ma'am.
Okay, so yes, so we need to know more about the routes of administering morphine. So what are the routes of administering morphine? Morphine can be given orally, intravenously or subcutaneously, rectally, epidural, as well as intrathecal. So what do you suggest now? How can we send this? How can we produce pain relief for this patient at home?
For
Yes,
rectal.
yes. Per rectal would be a better option for that patient. So this patient after 2 months was unable to swallow anything, including morphine. And what did we do? We converted the oral morphine to 5 milligram per rectal morphine 8th hourly. So the same tablet can be used per rectally. So you just put a drop of water and just make it a paste and apply it on the rectum. It is absorbed, well absorbed. So you can use it. The same oral tablet can be used per rectally and the patient can have adequate pain relief at home. Now, there is another patient scenario. This is Mrs. K, 55-year-old lady who was diagnosed with carcinoma of colon. She has abdominal pain, which is continuous in nature, and she was started on 10 milligram of morphine 4 hourly. And she doesn't require any SOS dose of morphine and her pain was well controlled. So now the doctor has asked to replace morphine with 25 microgram of fentanyl patch. Next day, the patient report to you telling that they replaced the fentanyl patch after 5 hours as she had no pain relief. What will you do? So the patient was having stable pain relief on morphine 10 milligram 4 hourly, and now the doctor has asked patient to replace morphine with 25 microgram of fentanyl patch. But after 5 hours, the patient removed the fentanyl patch saying that there was no pain relief. So what do you think or what will you do in such a scenario? Any idea?
Ma'am, you have to wait. Ma'am, you have to wait for 12 hours.
Exactly. Thank you, Rahimat, for that. So we'll be learning more about the fentanyl patch. So fentanyl, it is a transdermal fentanyl patch. And how does it act? This patch can be applied on the skin, intact skin. with no abrasions and no hairs. It can be applied. And what happens is that it forms a subcutaneous depot of the drug, and this is slowly released into the blood. And so the effective analgesia of the drug starts only in after 8 to 12 hours. And that is the reason why the patient didn't have adequate pain relief after 4 hours. So the patient was not having adequate pain relief after 4 hours, and the patient removed the patch. So this is because the effective analgesia could be produced only after 8 to 12 hours of fentanyl patch application. And this would last for 72 hours. And of course, the condition, the skin condition and the temperature has a role and will affect the absorption of the drug. The most important is that fentanyl patch is effective or can be used only for patients with stable pain. This is because, so when we say fentanyl patch is available in as 12.5 microgram, 25 microgram, 50 microgram. In our settings, these are the 3 dimensions in which fentanyl patch is available. So what does this 25 microgram of fentanyl patch means? 25 microgram of drug is being released every hour. And one patch can stay for 3 days, 72 hours. And the patch starts its action analgesic effect after 8 to 12 hours. And it is since this, which part do you want me to repeat, Elsamma? So fentanyl patch, it is when we say 25 microgram of fentanyl patch, it means that 25 microgram of the fentanyl is being released per hour. And this patch can be kept for 3 days, 72 hours, this patch can be kept. And to produce the effective analgesia comes in after 8 to 12 hours of patch application. And since this releases the drug, keeps on releasing the drug, patch releases the drug in a constant rate, like 25 microgram per hour, and we don't have any control. Once the patch is placed, we don't have any control. It is not recommended for unstable pain. Only if the patient has stable pain, we recommend fentanyl patch. Other preparations of fentanyl available are injection, transdermal, as I already mentioned, and you have oral transmucosal fentanyl citrate. It is lipophilic in nature and it is 100 to 150 times more potent than morphine. And 60 milligram of oral morphine equivalent per day is equal to 25 microgram per hour of fentanyl patch. So suppose a patient is on 10 milligram of oral morphine every 4 hourly. That is the total morphine dose in a day would be 60 milligram. That patient can be converted to 25 microgram of fentanyl patch. So that is the conversion from morphine to fentanyl. Now we have Mr. P, a 70-year-old man. I hope that was clear. Fentanyl.
Yes, ma'am.
Okay, thank you. Now, a 70-year-old man who had carcinoma of the lung had severe pain, a throbbing kind of pain. Sorry, not severe pain, 5/10 pain. Intensity of the pain was 5/10, which was continuous throbbing pain on the right front of the chest. He is a non-epileptic and is on levetiracetam 500 milligram BD. How will you manage this pain? Any suggestions? The patient is having 5/10 pain. It is a continuous throbbing type of pain. So,
Ma'am, we with weak opioid, like first choice of drug tramadol, and with adjuvant, then an anti-epileptic like gabapentin or Eptoin something.
okay.
We
Thank
use
you.
for pregabalin and gabapentin
Thank you,
also, ma'am.
Sunila.
Yes.
Sorry?
Use gabapentin and pregabalin combination medicines, ma'am, to relieve the pain.
Okay. So why do you want to, so the patient is having continuous throbbing type of pain. We didn't see any neuropathic component in it. Do you find any neuropathic component in it? Why you were suggesting on adjuvants? And the severity of the pain is 5/10.
We should give morphine by a syringe driver continuously.
Why?
Syringe driver subcutaneously.
Yeah, why do you want to give morphine? Why don't you want to try oral morphine? Samiksha?
Because of continuous pain.
Yeah, but the severity of the pain is only 5/10. So when we say 5/10, how do we plan the medications? Based on the WHO analgesic ladder, right? And
Yes.
depending upon the severity of the pain, the patient is having only 5/10 pain. So,
Before you use for SOS medicines, ma'am, whenever the patient's having the pain, so we give
Yeah.
the only SOS medicines. In case the patient's having the regularly pain means, we give the dose in frequency according to the conditions.
yeah. So this is a continuous pain with 5/10 pain score. Yes.
Only
So,
first.
yeah, many of you have responded that step 2 opioids or weak opioids would be the choice depending upon the severity of the pain. Why I put this question is because you might have gone in your previous sessions that tramadol is a drug which can reduce the seizure threshold. Even tapentadol, the weak opioids like tramadol and tapentadol can reduce the seizure threshold, and it is not recommended for patients with history of epilepsy or on anti-epileptics. So it is always advisable to start on a low dose of morphine for such patients, even though the patient's pain score is only 5/10 and it looks more like the step 2 opioid would be a better choice for the patient, step 2 analgesics. But since the patient is epileptic and is prone to have seizures, low dose of morphine would be preferable. So that is 5 milligram of oral morphine 4 hourly would be a better choice for this patient than going with tramadol or tapentadol, which can produce seizures. Just to remind this, I put it. So now we'll be looking in detail on opioids. So what are opioids? It's a general term which includes naturally occurring semi-synthetic and synthetic drugs which produce their effects by combining with opioid receptors. And these are antagonized by naloxone. So basically opioids, it can be naturally occurring, it can be semi-synthetic or synthetic drugs. And they produce their effects by combining with the opioid receptors. And these actions are antagonized by naloxone. This opioid receptor action are antagonized by naloxone. So what are the receptors? I told you this opioid drugs acts on the receptors to produce its effect. So the common receptors of opioids are mu, kappa, delta, and sigma. Sigma is not considered as a true opioid receptor. This is because its action cannot be reversed by naloxone. And the opioids can be classified based on their receptor interaction. Opioids can be agonist, antagonist, and agonist-antagonist. When I say opioid is an agonist, that means morphine is a mu agonist. That means that morphine binds with the mu receptor and together they produce the analgesic effect. So morphine, that is agonist. An agonist drug would bind with the receptor site and produce the effect. Whereas an antagonistic drug, what does that do? Naloxone is a morphine antagonist. When I say naloxone is a morphine antagonist, it means that Naloxone acts on the mu receptor and binds with the mu receptor, but it does not produce any effect. It does not allow morphine to bind with the receptor site and produce its effect. So that is the antagonist. So agonist, they bind with the receptor site and produce a effect, whereas antagonist, they bind with the receptor but do not produce any effect. They counter the effect of the agonist. So that is antagonist. And we have some drugs called agonist, antagonist. So these drugs, they have agonist action and some receptors, and they have antagonistic action and other receptors. So that is agonist, antagonist. So now moving on to the side effects of morphine. So the side So the side effects of morphine, this can be classified as adverse effects as well as toxic effects. So adverse effects with therapeutic doses is called the side effects. So what are any idea about the side effects of morphine? What is the most common side effect of morphine?
Constipation.
Constipation,
Very good.
nausea and vomiting.
Yes. Constipation, nausea and vomiting.
Sleepiness, ma'am.
Yes, sleepiness.
Loss of appetite.
And gets drowsy.
Yeah, drowsiness, itching, dry mouth, these are some of the side effects. So these are side effects means that even with the therapeutic doses, these effects can occur. So that is side effects. Adverse effects that occur with the therapeutic doses are called side effects. The most common side effect of morphine is constipation. So the others, nausea and vomiting, sleepiness, itching, dry mouth, urinary hesitancy can also occur with morphine. So around 95% of the patients develop constipation. And usually when a patient is started on morphine, we start with a stimulant laxative. It can be bisacodyl or it can be sodium picosulfate, usually given along with morphine. This is because the most common side effect with morphine is constipation, and as long as the patient is on morphine, the patient is likely to develop constipation. So the patient should be advised to continue with the laxative as long as the patient is on morphine. The other side effect is, as you said, 1/3 of the patients develop nausea and vomiting, but this is a self-limiting side effect. And this is due to the stimulation of the chemoreceptor trigger zone. So after the 2 to 3 days, this is a self-limiting. This emetic field gets overcome after 2 to 3 days. So the patient, when we start a patient on morphine, we prescribe drugs acting on the antiemetics that act on the chemoreceptor trigger zone, like haloperidol, metoclopramide, or domperidone. Any of these drugs should be given to the patient for 2 to 3 days. Starting with you might have noticed when we did the morphine, IV morphine titration also, we started with the injection metoclopramide. So this is important to avoid, an antiemetic should be given for the first 3 days. Other side effects include sleepiness and tiredness, and this is also self-limiting. So what is important is that you should inform the patient. The patient should be informed that they are likely to develop sleepiness and tiredness, which would get over in a couple of days. So otherwise, what happens? The patient will not take the medication. They feel tired and sleepy, and they feel that the medicine is causing some issue and they will not take it. So just inform the patient that they are likely to develop sleepiness and tiredness, and this will get over in 2 to 3 days. So first 2 to 3 days of medications, this would occur. Patient can feel nauseated and vomiting, so they need to take an antiemetic. Then sleepiness and tiredness can occur. So, but this will get over in the coming days. Now, moving on, that was the side effects. Now, what are toxic effects? Suppose the adverse effects that occur when the administered dose is higher than that required for pain relief, or when the pain has poor response to the opioids. It is called a toxic effect. It brings about toxic effects. So it is the adverse effect when the administered dose of medicine is more than that is required for pain relief, toxicity set in. And that includes delirium, myoclonus, drowsiness. These are the common toxic effects that the patient might present with if the patient has been given doses higher than that is administered doses that is higher than that is needed for adequate satisfactory pain relief. So, does opioid produce respiratory depression? What are your thoughts on that?
Yes. Yes.
Yes. So, in my experience of last 10 years as a palliative care physician, I have not seen a single case of respiratory depression due to morphine. Having said that, this is because if the medications are given as per the principles of analgesic use by orally, that is by mouth, by the ladder, by the clock, then there are very rare chances of developing respiratory depression. Indeed, there is no chance because monitoring the toxic effects, if you titer the morphine slowly as per the watching for the toxic effects, if it is done, there are very less chances of developing respiratory depression. So, but when does this occur? Usually, when a respiratory compromise occurs, if there is an indwelling pneumonia or a pulmonary embolism, or the drug is co-administered with some benzodiazepines, we need to be more cautious. But if cautiously we have titered the dose and watched for the toxicities and properly monitored, then there is very less chance of developing respiratory depression. Does opioid causes addiction?
Yes.
Yes, ma'am.
Yes. So as per the literature, so the substance abuse due as a result of medical use is very low. So as part of medical use, this addiction, the likeliness of developing addiction is very less. So that is what the literature says. And there have always been a confusion between physical dependence and psychological dependence. And so actually the physicians themselves are overestimating the risk of addiction. So due to the fear of addiction, they are not confident enough to prescribe the medications as per the need. So that is what the research says. So the substance abuse, when as per the due to medical use, is very less happening or very low it is. And usually there is due to the risk of addiction, there is an overestimation that they feel that there could be addiction could develop, and due to the fear of that, the physicians are very reluctant or not confident to prescribe medications to the needy patients. That is what the literature says. So now, what is physical dependence and psychological dependence? Addiction. So I have As per the American Academy of Pain Medicine and American Pain Society and American Society of Addiction Medicine, this is the definition for psychological dependence. Addiction is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. Impaired control over drug use, compulsive use, continued use despite harm, and craving. That is psychological dependence. And physical dependence, it is a state of adaptation that is manifested by a drug class specific withdrawal syndrome. So, how many of you drink tea in the morning? How many of you feel that, how many of you cannot, like, if you don't drink tea, how many of you cannot manage without drinking tea? Is there anyone who finds it difficult to manage without drinking tea? Can you please unmute and talk?
Yes, ma'am. Sometimes, if I don't drink tea in the morning, by evening I will get headache. Not usually, but some days.
You have that headache. Okay.
Yeah.
Thank you, Ashwati, for that. Okay, so Pradima says that she feels something missing if she doesn't drink tea. So suppose Ashwati, today morning Ashwati went to the kitchen and found that she doesn't have the tea leaves or tea powder for making tea today. So Ashwati lives in a flat, and near Ashwati lives Sheetal. And Ashwati knows that Sheetal's kitchen there is tea. I don't know which places are you all from, but I'm just telling. So,
Yeah.
so Ashwati knows that Sheetal's kitchen there is, but Sheetal is out of station. So what Ashwati does is that she normally develops headache if she doesn't drink tea. So what she does is that she breaks open into Sheetal's kitchen and get the tea powder and make the tea and drink. This is psychological dependence. So despite knowing that this is not, what she does is not good, she understands that breaking open into somebody's kitchen is not something which we should do, but she's doing it. That is out of psychological dependence. But she develops headache if she doesn't drink tea. That is physical dependence. Our body has been trained since long. She has been giving tea to the body since long. So the body is not receiving that. So it is a withdrawal syndrome from the body that is shown as a headache. Just to make it simple than the big definitions, I hope it made some sense to you. I don't know. So this is just to differentiate between psychological dependence and physical dependence. Yes. So next is, just to give you an idea of the drug, its equipotent dose and cost. So whenever your doctors prescribe some medications, it is very important to understand the expenditure that the patient has to bear when this is being prescribed. So you can see that morphine 5 milligram 4 hourly, if a patient is prescribed, that is 30 milligram, it costs around 3.50 rupees per day. And the equipotent dose of tramadol cost around 24 to 50 rupees. And the same of fentanyl patch, which is 12.5 microgram, cost around 250 to 400. And that of methadone, 5 milligram, is only 4.50 rupees. This is just to give you an idea when you do the prescriptions or when you see your doctor's prescribing, just to see, understand the economic status of the patients and do the prescriptions. Yeah. So I think with that, I have completed my session. It's open for discussions. If you want to discuss something, we can discuss. And after that, I think we can move on to the case presentation. If you have anything to ask, please unmute and ask. We can discuss, or you can put it in the chat box.
Excuse me, ma'am. Madam, you had mentioned that morphine will be metabolized in the liver. So if the client is having any liver diseases, in that case, whether there will be any effect on that, or is it safe for us to give morphine to any such patients?
So there also, yes, I'm sorry I didn't respond. It was in the chat also. Thank you for that question. So yes, morphine is metabolized in the liver, and that means that if in hepatic issues, the liver will get compromised. So we will have to go with increase the reduced frequency or increase the spacing between the doses. Suppose the patient is on 10 milligram of 4-hourly medication, it is advisable to make it 6-hourly dose. So 10 milligram of morphine 6-hourly would be a better choice. So depending upon the toxicities, you will have to either reduce the frequency or reduce the dose, whichever you feel is more applicable to the situation.
Thank you.
Yeah.
The dose of fentanyl injection. Okay. Hello.
Somali ma'am, go ahead, ma'am.
Dose of fentanyl injection. How much dose is to be given?
So, ma'am, that is are you talking about the titration or?
Injection fentanyl dose.
Yes, ma'am. So the dose would be depending upon the patient's pain. So the opioids in generally doesn't have a ceiling effect. The pain and the toxicities would be the controlling factors. So depending upon the severity of the pain, we need to modify the dose. So for fentanyl, you can also do injection fentanyl IV titration can also be done. But the difference is that 2 ml of fentanyl contains 100 microgram. So 2 ml of fentanyl, you need to dilute with 8 ml of NS in such a way that 10 ml contains 100 microgram. So 1 ml will contain 10 microgram. So every 3 minutes is the titration interval for fentanyl. Because as I said, it is lipophilic, it has faster action. So fentanyl can be given once in every 3 minutes. 10 microgram in 3 minutes would be the titration. I hope I'm clear to Somavalli ma'am.
Thank you, ma'am. I'm clear.
Yes. Yes. Can we move on to the?
We can move on to the case presentation. I welcome Raji here for presenting the case.
Good evening, ma'am. Good evening, everybody. My name is Raji Kaya. Currently, I'm working in Medical College Thrissur as staff nurse. I want to discuss a story of my patient. As a female patient, 63 years old. She is diagnosed with the left ankle abscess. And move on to the presenting complaint. Patient got admitted due to a sudden slip or fall before 3 months, and she got injured to the left ankle and sustained traumatic left ankle, and presented with complaints of pain, swelling, and deformity. Move on to the history of illness. As part of this slipping or fall before 3 months, um, she have some complaints of trauma over this left ankle. Following that, she walked 1 month when she uh, feels some relief from that pain, and suddenly she developed difficulty in walking and consulted in local hospital. Now she came with a complaint of pain and swelling over this left ankle, and deformity. On examination, she's well moderately nourished and body built, and on examination, not palpable lymph nodes, and abdomen was soft. There is no organomegaly. Only for that left ankle have the deformity, tenderness, and swelling, and limited movements. When she is moving around a simple step, she feels very much of pain. And on examination, there is a pulse, and movement is very dull on these times. Move on to the treatment and significant investigations. On the admission, on the first fall, X-ray shows all the unity of the left talus fracture, and the blood investigations, electrolytes are normal, and random blood sugar level 161 mg per dl, and total count 10,000 sulfur cubic millimeter of blood. Then we move on to the psychosocial aspects. She is 63 years old, widowed woman living with her son in a rented house. Her son is the breadwinner of the family. She is worked in a bakery till the fall. The entire family struggled to survive from this situation due to the recurrence of this pain and immobility. So she wishes to relieve from this sustained pain and do the daily activities without help. Coming to the medication, she's getting medications like we are already know she has apples over the left. So we are start some antibiotics like taxine 1 gram IV 2 times a day, and gentamicin 80 mg IV BD, and also metrozole injection metrozole 500 mg IV BD. And for pain, we put some medications like tramadol 50 mg along with the Mr. 4 mg IV BD. And if she feels pain, then we give tramadol for SOS, and we have some vitamin and calcium for the daily medicine. Now she has some main complaints of there is some financial issues as well as the deformity to do the daily activities, and we are discussed about she can't able to continue her work due to the limited mobility. As per the summary, 63 years old lady suffering the recurrent occurrence of this pain and deformity of the left ankle, and which I mentioned earlier. She needs a pain controlled daily activities, and she takes pain medication 2 times. So sometimes takes if she take a single steps or movement, she wants to take the medications at a time. I think the discussion points are related to whether do she need the palliative care, and what are the problems faced by the patient, and what can we do for this family? Okay. Thank you, everyone. Thank you.
Thank you, Raki, for that presentation.
Thank you,
And
ma'am.
yeah, so I would request the participants to come up with their views on the discussion points. So the first question that Raki wants to know from you all is, does she need palliative care? Please bring in your comments on that. Summary.
No, ma'am. But research and the Ma'am, no need to give the palliative care. The main reason she is having the problem of fracture. So try do the surgery for the fracture. So otherwise our appetite level, sleep patterns, there is no bed. So she's able to mobilize. So she's not go for the palliative care.
Okay, thank you. Thank you for that response. Anybody feeling that? Yes, Ashwati, do you want to unmute and talk?
Hello. Yes, ma'am. In the history, it's not showing any content of any emotional expression or spiritual delay or anything like that. So some components of the palliative care is missing from the history, I think. So I think we need to focus mainly only on the physical aspect right now, the pain reduction and the deformity correction. So I don't think she requires a palliative care at this moment.
So, so what is palliative care?
Pain management.
You had a class on palliative care?
Care means we relieve the patient from their suffering in a holistic approach.
Yeah. Yes. Thank you. Thank
And
you.
this palliative care we give to the patient on the time of treatment only, like
Time of diagnosis.
diagnosis, at the
Yes.
time of diagnosis and the ongoing treatment.
Yeah.
Yes. Yes. Thank you.
Actually, this patient need a palliative care because she is on pain. Yeah.
Yes. Okay. Thank you. Thank you for the responses. So, yeah. Yes, Mangai. So, this patient is in a health-related suffering, right? The patient is undergoing a suffering. So, any patient with a serious health-related suffering would benefit from palliative care. And of course, her quality of life is compromised. So, a holistic approach to this patient, including pain management and also the other aspects of care, like the psychological and social and spiritual aspects, can improve the quality of life of the patient. And of course, we have not much mentioning about the caregiver of the patient. So that also, the family of the patient also needs to be taken care of. And so this patient would definitely benefit from palliative care. And at the same time, the curative treatment should go hand in hand along with the supportive care. That is what I feel. And of course, what I would like to tell you is that whenever a case presentation is made, it is well and good if it is based on the discussion that day. So today we had a discussion on opioids. So if a case discussion is based on that, that would be more beneficial to the team. So, and we have no description of the pain of the patient here. You have already learned the PQRST of the pain. So that needs to be explained. What is the type of pain? What is the severity of the pain? How much relief? So she is on injection tramadol twice and SOS. So that could be like, if we need to know more about it. Raki, is the patient having adequate pain relief with this injection tramadol?
Yes, ma'am.
Yes.
Yes.
Okay. Okay. So that means step 2 opioids would help the patient. If not, if the patient was not having adequate pain relief, then we will be thinking in terms of opioids. Maybe the stronger ones of step 3 opioids, we might think in terms of that. And of course, there would be an inflammatory component. So NSAIDs could help in this patient.
Okay.
So I think it would be good if the patient story you choose would be based on the topic discussion on that day, then that would be more beneficial. And for this patient, I think the main discussion points were, yeah, so taking back to the topic of today, I would say, or I feel that this patient, if the patient is having adequate pain relief with tramadol, then the patient can be continued on tramadol as long as the patient has pain relief with that. If not, we can step up to morphine. Initially with a lower dose of morphine, tab morphine 5 milligram 4 hourly, and depending upon the pain relief, we can increase the dose.
Okay.
Yeah, that would be my suggestion for this patient. If anybody has any other inputs, please do share. And of course, we need to understand all the aspects of care, the problems faced by the patient, not only the physical part, the other aspects of sufferings also needs to be addressed. For that, we need to understand in detail about the psychological status of the patient and more into the spiritual aspect also. And holistically, we can plan how can we help the family out with the support of the community. Can we do something? You said financial constraints are an issue for the patient. So if there are some ways of helping, any volunteer support or coming from the community, and fundraising possible from the community, these are ways by which we can think and explore how to support the family.
Okay. Thank you.
Yeah. Does anyone wants to add anything more to it? Please feel free to do that. Or if there is anything more to discuss, please ask now. Otherwise, we can wind up the session.
Oh, excuse me, ma'am.
Yeah, please go
Ma'am.
ahead.
Ma'am, I want to ask this question. There was a question in our pretest that says that whether with a patient of drug abuse, history of drug abuse, what dose of morphine should be given, like according to the pain? Can you please elaborate on that?
Nanshi, who said?
Oh, yeah.
Yes, ma'am. Yes, ma'am. I'm here. Yes.
Yeah, I'm so sorry, Nanshikola. I'm not aware of the question that was given to you. Definitely,
Okay.
Yeah, Sangeet can connect with the coordinator and they can get back to you for that.
Shiva ma'am will get an answer.
Okay.
Yeah.
I'll connect you with you, Nancy.
Okay, ma'am.
Maybe
Okay,
you
ma'am.
can
Thank you,
get
ma'am.
an answer for that during the next session.
Okay, ma'am. Yeah. Thank you, ma'am. Thank you.
Yeah. So I think thank you for being such a wonderful audience.
Thank you, ma'am. Thank you for the wonderful session. Thank you all for the.
Thank you, ma'am.
Thank you. Thank you all for being cooperative.
Thank you, ma'am.
Thank you. Let's all see you in the next session. Bye.
Bye.
Yeah.
Take care.
Bye
Bye.
bye.